My name is Mary Baines and I'm a doctor, and I've been a hospice doctor in palliative care, I guess longer than anybody, as I started in April 1968. Perhaps I could go back to Cicely Saunders, really, who started the whole thing. Cicely, while she was working at St Thomas's and in the hospitals around as a social worker, met this young Polish man. His name was David Tasma, and he was a Polish Jew who'd escaped from the Warsaw ghetto and come via Paris to London, where he was working as a waiter. And this was in 1948. And then he developed cancer, from which, when Cicely met him, he was near the end of his life. And she visited him quite a number of times, both in St Thomas's and at home, and the two of them got very close, emotionally very close. And through her friendship with him, she saw that his needs, which were many, were not being met in that busy surgical ward. He had severe pain, physical pain, which was being badly controlled by the methods that were used then, giving injections when the pain was unbearable. And he had what she later on talked of, emotional and social pain. He'd come from Poland. All his family had perished in the Holocaust, so he was entirely on his own. And he had nobody to talk to except his social worker. And he had what Cicely later termed spiritual pain. He'd been brought up a practicing Jew, but since he'd come to London, he hadn't practiced his faith, and he didn't know whether he believed in God or not. Cicely later on went on to describe the essence of palliative care as being the relief of total pain, physical, emotional, social and spiritual. And she learnt that at the bedside of that young man. Then when David died, he left her all the money he had, his life insurance, £500, with the words, "I will be a window in your home," as they felt that there was a better way of looking after, not after that David, but the Davids of the future. So there was Cicely. She was then in her early 30s. She was a nurse and a social worker, and she had this call, which she believed came from God, to do something to improve the care of the dying. What should she do? She was advised by the doctor she worked with, the surgeon, that she should train in medicine. And that meant starting with the physics and chemistry of medicine at the age of 30 plus, not at all easy. She did this at St Thomas's, and then she went on to the preclinical, and it was in 1954 that I joined her as a medical student, clinical medical student at St Thomas's, having done my preclinical part at Cambridge. And we were exact contemporaries. But she'd gone into medicine to care for the dying. St Christopher's was opened in 1967, and having been a medical student, exactly contemporary with Cicely Saunders, she invited me to join her on the staff when it opened. And with much fear and trepidation, I finally agreed. When St Christopher's was opened, this was purely an inpatient unit, as were all the other hospices of that time. A number started at the turn of the century. St Joseph's in Hackney, for example. These were inpatient units only. But Cicely had had a vision of something in the home, but without any particular shape for it. And then, in 1969, 2 years after it opened, and a year after I joined, an event happened which I think of as the sort of catalyst for home care. A woman in her 50s with breast cancer had come into the wards of St Christopher's. Her severe pain had been well controlled on a combination of drugs, including a moderate dose of diamorphine, the strong opioid we then used. But she surprised us all, amazed us, particularly Cicely, by saying something like, thank you very much, it's very nice here, but I'd like to go home, please. Which is not what people did. So I did all I could to make that possible. I rang the GP, discussed her management, gave her a supply of the drugs, we said goodbye to her, and home she went. And 10 days later, we had a distressing phone call from her husband to say his wife was in agony and would we please readmit her, and that we did. And it was then that we found out what had happened. The GP'd gone round, been alarmed, terrified by the drugs she was having, had slowly reduced and stopped them. He was afraid that we'd turn this lady into an addict. And of course the result was that her severe pain, which had been well controlled, all came back again. The story goes on in that it was easy to control her pain again, but sadly, very sadly, she lost her nerve and never wanted to go back home again. And she stayed in St Christopher's until she died. And it was that episode which made Cicely say, we must now start hospice care at home. I was exceedingly thrilled by some of the presentations at the conference. Julia Riley spoke about coordinate my care, and Anthony Byrne spoke about information, the key to good symptom control. And what this was an attempt to do was to offer to a huge number of people the sort of care that in the early days of home care we offered to a few. Soon after we opened, we had about 80 people, something like that, at home on most days. They all lived within a 6-mile radius of St Christopher's, and we had a team of 4 nurses who visited them and myself. And we knew about every one of those patients. New patients were presented to the team, problems were discussed, so that if we were called and asked for advice, we knew about them. What's happened now? There are 850 people at home. Isn't that great? These people getting the sort of care they need. But it stands to reason that you can't know 850 people as you knew 80. And thank God we now have computerization, and these are, the 2 talks were both about computerized records that could be accessed by a nurse on call at night to offer these people the same, or not the same, but as good as individualized personal care 24 hours a day that our little team at the beginning did, because the numbers were small, but now needs to be extended out to the thousands of people. St Christopher's has 2,000 new home care patients a year. And I was thrilled by that.
Wonderful.
And the other thing that thrilled me was a presentation by Barbara Gomez on research. And what has happened in this country is that the percentage of deaths at home has been steadily going down over a very, very long time. But now, in the last years, it's begun to go up for the first time for ages. Please don't think that I think this is all due to palliative care at home. Of course it's not. But I think it's changed the culture and made people realise that if people want to stay at home until the end of their lives, then it's a very worthwhile thing to enable them to do it well. Yeah. Well, I was obviously very excited with the conference because, as far as I know, it's the first one ever that has focused entirely on care at home, which is the great part of palliative care. And some of the presentations certainly I need, and I think everybody needs, to really be able to go over in text form to take in, because they were very detailed and very, very relevant. the use of computerisation to enable knowledge to be dispersed to everybody who's caring for patients. The very fascinating bit of trying to cost palliative care at home and different ways of doing that. Some of the difficult symptoms to manage at home, particularly breathlessness, and then a span from the world, many countries of the world, and how palliative care has impacted on them. So I think it's a quite remarkable conference, and it will be a quite remarkable and important journal.